Good afternoon, everyone, and welcome to our first town hall of 2026, Homelessness in San Francisco, Lived Experience and Solutions from the Frontlines. My name is Lillian Archer. I'm the Chief Advancement Officer here at St. Anthony Foundation. On behalf of the board, our volunteers, the guests we serve 365 days a year, we are so grateful to see so many of our neighbors here today. Whether you're a public leader, a healthcare provider, a community partner, volunteer, or donor, you're here because you care. For 75 years, St. Anthony's has opened its doors to neighbors facing homelessness, poverty, and addiction. We've served millions of meals, provided health care and clothing, walked alongside people in recovery, and witnessed countless journeys towards healing. But our most important work is not measured in numbers, it's measured in relationships. Today's conversation is an opportunity to create space for honest dialogue, space where we can listen deeply, learn from one another, and understand what truly helps our most vulnerable neighbors. The voices you'll hear this afternoon don't just study homelessness, they live the work. They understand what happens when someone is genuinely encountered, when dignity is honored regardless of choices made, when neighbors are met exactly where they are. This gathering reflects our Franciscan calling as a convener, creating space where understanding can deepen and community can grow in compassion. So thank you for being here, for caring, for staying present even when the answers aren't easy. Before we hear from our panel of experts, it's my honor to introduce former St. Anthony's board member and now City Hall's Chief of Health, Homelessness, and Family Services for our city and county of San Francisco, my friend Kunal Modi.
Well, thank you, Lillian, for inviting me to speak before all these brilliant people, because I know they will be a tough act to follow. I'm really delighted to be here. Every time I get a chance to speak at a St. Anthony's event, it feels like a real homecoming. My journey to this role on Mayor Lurie's team in many ways can be traced back to my time as a volunteer in the dining hall at St. Anthony's. It was there that I got to learn about so many of the stories of people who pass through the dining hall every day and the challenges they experience and the aspirations they have. I also got to learn a lot about myself and our broader community. If you haven't spent time there, I would deeply encourage you all to do so. It's really shaped and continues to guide the way I think about my role now in City Hall, what I learned there in St. Anthony's. From the mayor's office perspective, there's really three big principles that guide our work as it relates to everything that our panelists are going to talk about today. The first is that all this conversation needs to be rooted in the specific challenges of the communities that we're aiming to serve. We use big words like homelessness as a stand-in for lots of different challenges, and oftentimes the person in front of you is experiencing a complicated intersection of homelessness and sometimes behavioral health challenges, sometimes drug addiction, poverty. And so really thinking about being clear-eyed around what challenges we're trying to solve, because if you really understand that, you're going to have a different set of interventions. And so we're trying to be more conscious and not use generalities. I think that's part of the challenge that we've run into over the past 10 plus years, was solving one problem, maybe homelessness, and not really as much solving crises on our street that are really present, including drug addiction and behavioral health. So we're trying to recenter that. We're also trying to think about, when we think about our folks that we aim to serve, the broader public. I always like to remind our community, public health means the whole public. That means we need to both care for those individuals in crisis, and we also need to think about the kids and families walking through the tenderloin and the trauma they endure through seeing public drug use, seeing what our community deems as acceptable, and they too are deserving of our compassion and our public health strategy response. The second big principle that we focus on is thinking about the journey. We have a habit of organizing response systems around governmental departments and programs. And so things around like, oh, well, this can be licensed for 24 hours and this can be licensed for 90 days. And that's not really how people's lives are lived. And so thinking about how do we bring departments that don't always have a history of working together in much closer collaboration, so that when we do this work, we're actually thinking about how we support someone who may be in crisis on the street to come indoors, get the care and supports, and actually to get on a pathway of recovery and independence. That is ultimately the goal, and having that be personal to the folks we aim to serve. And then the last big principle that guides our work is to be really focused on data and common sense, not dogma. There's lots of big labels and terms and nasty fights that I've come to become a part of this conversation in San Francisco. It doesn't always serve us well. Oftentimes I find when we get underneath it, there's more agreement than there is disagreement. And so just really trying to focus on what are the things that are common sense that can guide our policy, I think have helped us advance some different solutions. And then the last thing I'll say is just not being afraid to talk about third rails. This has been a crisis for a long time. I don't think any of us want to be sitting here in 4 years going to a discussion around how do we tackle this crisis. I think there's an urgency that we all feel around how do we confront this and get ourselves on a structurally different path sooner rather than later. And so I hope that's what we hear in today's discussion, is tackling some of those third rails, helping these very brilliant thinkers, many of whom have been working on these issues for decades in places like Boston, in other words, help us learn kind of how we can break through where maybe we haven't had a chance to before. So with that, just thank you again, Lillian, and the entire St. Anthony's team. St. Anthony's is such the mayor said earlier this year, St. Anthony's is the moral compass of our city. I deeply feel that way, and so thank you for holding this space for us to have this conversation and for continuing to bring people together around these complicated topics. It's an important part of how we're going to get to the types of solutions that I think we all want for our community. So thank you.
Thank you, Kunal. And what's also important about this dialogue is the opportunity to hear about the lived experience, which is so critical to understanding the issues, the care, and the journey to recovery. So I have the pleasure of introducing Ranjit Bar, a powerful example of what is possible when people experiencing homelessness are met with dignity, opportunity, and belief. Ranjit is a former St. Anthony's guest who is now an employee of St. Anthony's and was recently promoted to dining room volunteer coordinator. Very proud of you, Ranjit. A little bit of a job description. He helps welcome volunteers and ensures thousands of neighbors receive meals each day with dignity and care. He embodies the spirit of St. Anthony's accompaniment, resilience, and belief in human potential. Please welcome Ranjit Bar.
Thank you all for being here today. This topic is near and dear to my heart, and it's truly meaningful to see how many of you here are open, engaged, and willing to have this important conversation about homelessness. I was born in San Francisco at General Hospital on March 10, 1981. My mother was Irish, and I was adopted by my father, who was Indian. At age 5, I was sent to India for my education to attend an Indian military boarding school. I didn't return home to the U.S. until I was 13 years old. I still remember how hard it was there for me, not to speak the language and being the only person of my color. I remember feeling abandoned by my parents and feeling like I would never see them again. At 13, I returned home to Live Oak, California, a small town above Sacramento with a population of 6,000. Once again, I found myself an outsider in school, not being accepted, feeling very lonely, so I mostly stayed to myself. My parents gave me a good life. I had everything needed and more, and I felt somewhat privileged. But I still longed to be accepted at school. I always felt like there was something wrong with me, the feeling of not being good enough, feeling sad and lonely. A few years had passed, and I finally fell into a group of individuals who, for the most part, were kids from the street and are all gang members, and eventually became one myself. This lifestyle taught me how to survive the streets. And this lifestyle scared my parents, and they tried to prevent me from going down this destructive path, but it was too late. When I was 17, I got shot, and my mother moved me and my brother to Tennessee, where 6 months later, she passed away. Once again, feeling lonely and abandoned, and having to raise my brother, I turned to the streets to survive. At 20 years old, I had my first child, a boy, and decided to move to Florida for a new start. In Florida, I had a second son with another woman and eventually had a daughter. This period of my life seemed somewhat normal, even becoming a business owner. But I was still living a double life. I was trying to be a good provider to my family, but still doing criminal activities in the street. On April 30th, 2012, I was gunned down by a 15-year-old kid and shot 8 times in front of my family, which left me paralyzed. Once again, feeling lonely and like a burden to my family, I tried to take my life. Eventually, I recovered and learned to walk again, but by this time I had developed an addiction to opiates, which eventually led me to heroin. This destroyed me and my family, so I decided to come back to California to try to fix my relationship with my father. But my addiction had me in the grip, and my father wanted nothing to do with me. So I went to the one thing that I knew, the streets. I became homeless at this point and burned everybody I knew. While homeless, I broke into abandoned homes and buildings. I saw this as easier than staying in a tent, because staying in a tent, I was still in the elements. I would stay in these places until an owner came or somebody figured out I was there and called the police. Being homeless made me feel such rejection, shame, despair, and truly hopeless, wondering if my life would ever get better. This led me to be incarcerated. When I would get released, I would always return to the same behavior, with nobody to call for help and going back to the streets, and the comfort of drugs seems to be the only option I had. It made me feel like I was losing my sanity and didn't think I was ever going to make it. I felt defeated. On November 30th, 2021, I was arrested for multiple felonies. I received a multiple-year sentence. While being incarcerated, I became desperate. But this might have been a blessing in disguise. The gift of desperation birthed a desire to find a new way of life. While incarcerated, a caseworker told me about St. Anthony's, the Father Alfred Center, a year-long recovery center here in San Francisco, where they can help me in all areas of my life, from drug addiction, employment, housing, and more. I was told that by the time I graduate the program, I will have gained the necessary tools to be a productive member of my community. This gave me such hope in time when I so desperately needed it. 2 years later, when I was released, I went to Father Alfred Center, which was everything I hoped for and more. The bonds that were created with my peers are now part of my support group and are lifelong relationships that I hold dear to my heart and that are here tonight. I now work for St. Anthony's Foundation and recently got promoted as a volunteer coordinator. Witnessing the power of connection during my time at Father Alfred Center, I knew I wanted to foster the same sense for others. I wanted to be a volunteer coordinator because I saw myself being part of a dedicated group who wanted to make a difference in our community. I have my own place and just celebrated 4 years drug-free. This has allowed me to pursue a dream as an artist in the tattoo industry. I owe so much gratitude to St. Anthony's Foundation for teaching me how to be the best version of myself. Thank you.
All right. Hello, everybody. My name is Keith Humphreys. I'm a professor of psychiatry at Stanford University. More importantly, I'm on the board of St. Anthony Foundation, and my role tonight is to moderate the discussion we're going to have with these national leaders in the area of homelessness. They're all tremendously accomplished. We could fill the whole time just reading their incredible list of achievements. But with their consent, we're going to keep the introduction short so we can maximize the time for them to share the great knowledge that they have. So let me introduce them to you, starting on your left. Dr. Jim O'Connell. He is the president of Boston Healthcare for the Homeless Program and a national leader in homelessness innovations and policy. Next to him is Dr. Larry Kwan. He is the CEO at St. Anthony's, celebrating its 75th year in the heart of the Tenderloin. Next to Larry is Beth Stokes. She's the Chief Executive Officer of Episcopal Community Services and an expert on housing programs and a long-term friend of St. Anthony Foundation. Next to her is Dan Tsai. Dan's had a very distinguished career in public service, including running the Medicaid program in the Biden administration. And then he joined Mayor Lurie's team as Director of Public Health for the city and county of San Francisco. And next to Dan is Kevin Fagan. If you read the Chronicle, you know Kevin Fagan's name as the very skilled and well-respected homelessness reporter for many years, and now an author of a book, which is out front and is very good. I'll put in a plug for it, called The Lost and the Found. Please join me in welcoming them all to this forum. So I thought at the beginning, oftentimes when we talk about complicated problems, we assume everybody knows what we know, and they know what we know what they know, and usually that's wrong. So I thought I'd begin with something just kind of simple. Give each of our experts here up to 2 minutes to educate us on something we might not know. And Beth, I'm going to start with you if I could. What is something most people don't know or understand about how our city's housing programs for unhoused people actually work?
Thank you. I'll just hold this up here. It's great to be here, with such an esteemed panel, and thanks all of you for coming out tonight. I'm really excited to have the conversation. I always appreciate the opportunity to be in community and to talk about the issue of homelessness and, also some of the great, movements and opportunities that we've all experienced together in the field. But to answer your question, because this is a mixed audience, I see some folks here that I've known for years who are in the field, and some folks that I'm just not quite sure how much you know about the topic. And so one of the things that I would say people may not understand about our city's housing programs is that it's not a first come, first served basis, right? It's not about who advocates, the loudest as a nonprofit, or, it used to be that way, right? So folks that may have been able to get to a provider or a housing, building that had an opening for a unit and could get there at, 1 p.m. on a Wednesday, was able to access that housing. And so it was really keeping out some folks that had high acuity and high needs who may have had issues getting to that location or not keeping up with the openings. And so the other thing I want to just say for folks that do know a lot about the field, so not a first come, first served basis, right? It's based on acuity, right? And folks who have chronic homelessness and complex issues. And that comes through the Department of Public Health and the Department of Homelessness and Supportive Housing in partnership with nonprofit providers who do some of the assessments. It goes in, and those referrals are made by the city and county. But for those folks that do know a lot about the field, and I know I only have 2 minutes, it's that this coordination around high acuity and moving people into housing really just started in San Francisco in 2018, late 2018. I'm going to say maybe November or December, and then we had like a year to kind of coordinate, and then we ran into the pandemic, right? So things then kind of were moving around a bit. The process kind of got a little bit confusing, and then we came out of it, and here we are with coordinated entry. And I'll say this, that, you know, we have a very complex, high acuity population moving into this housing intervention at 100% tenancy, right? And it's fairly new, right? And so our ability to adapt to that acuity has been difficult. So to share that with folks here for the provider community, it has been challenging. And so that's what I will start with. Thank you, Doctor.
Thank you, Beth. So, Dan, what is something most people don't know about how San Francisco tries to improve the health of people who are homeless?
So I have the privilege of being maybe one of the newest people in this room to San Francisco, having been in my role for just under a year. And there are a lot of things that are incredibly unique about San Francisco and California that you don't find anywhere else, even coming from Boston and Massachusetts, where I did used to volunteer at Boston Healthcare for the Homeless with Jim's team, and you know, that was a very special experience. But in San Francisco, we're both a city and a county, and the Department of Public Health includes the entire safety net healthcare delivery system, San Francisco General Hospital, 14 primary care clinics, 19 mental health clinics, a bunch of street health and shelter health and things of that sort, alongside contracting with community-based organizations for a range of services. So it's a very wide breadth. I think that's where most other localities you have either the state handles many of those things, or if you go to Los Angeles, so many parts of DPH are actually separate agencies. So that presents an amazing challenge and privilege. I mean, we have it all here kind of in one place in San Francisco, and we are, relative to the rest of the country, even again coming from Massachusetts, incredibly well-resourced. And we have many, many different programs that I'm very, very proud of when having gotten to know the city. Where there is real opportunity is sometimes I see so many different programs, whether it be things that we run, you know, with DPH staff in our clinics, or contracts we have with the community that are amazing on face value, and I appreciate them. They don't always fit together in a system of care. And by that, I mean, if folks on whether unhoused or in permanent supportive housing with clinical needs need access, are ready for treatment and services, sometimes we can get them into that incredibly quickly. Other times we can't. We also have a very fragmented system where we'll get someone into a particular clinical program, and what happens next is less clear or certain. Those are not faults of folks, but those as a system, all of these resources don't always help folks be able to successfully get access to care and treatment when they're ready, and to be able to successfully proceed through that. I'm sure we will talk more about street and homeless, kind of working with the unhoused on the streets, and there's a lot more I could say to that, but coming from outside of San Francisco, what we have here in San Francisco is incredibly unique. We are very blessed for that, and there's so much opportunity for how we actually get at the outcomes of serving folks and helping folks progress in their journey of treatment and services, recovery, and all of that. And that is very exciting and daunting all at the same time.
Thank you, Dan. So, Jim, you are very well known as the leader of Boston Healthcare for the Homeless. Can you tell us something most of us would not know about how the healthcare system interacts with people who are living on the street?
Sure. And first of all, I wanted to say thank you for having me here. I'm actually even newer to San Francisco than you are, Dan. But
that might be
I've been
true.
here about 24 hours now. But
And yet you still haven't solved our problems.
oh, give me another 20. No, I said,
24 more hours, but that's it.
no, and I have to, it's such a delight to see Dan, because you may not know, but he was also the Medicaid director in Massachusetts before he went to run the government. And while he was there, I know we gave it away a little bit, I can remember the first time I really met him, it was this guy cutting hair at our respite program, this volunteer. And I asked somebody who it was, and he goes, "Oh, that's the Medicaid director." And I'm like, "What?" So Dan had been volunteering for years, and everybody back home said to say hello to him. By the way, we cherished his presence and his leadership. The other thing I can't help but say, I went to St. Anthony's today for the first time. Larry took me through, and I've been hearing about St. Anthony since I started in 1985 doing this job. And it's always been one of those things we look to in Boston as one of the programs that has been most out there in the middle of taking care of people. And to see it in live today was just mind-blowing for me to see, I went to the kitchen where the dining room was, and we went upstairs where the clothing room was, saw the clinic, saw where everybody was sitting at a computer, which was more of a therapeutic session than anything else. It's just stunning. So I just want to say it's a privilege for me to be here. And then the very last thing I have to say, and I'm so sorry I'm diverting a little bit, but I will do it in 30 seconds what you meant. But I actually have seen some old friends here that I've been working with on and off for 41 years. So there's, I see Josh Bamberger there, Dr. Bamberger, Dr. Barry Zevins, Dr. Dan Vladarchik, all of whom were doing healthcare for homeless people as far back as I can remember. And then the San Francisco program is led by Bob Prentice, who is one of our heroes in teaching us how we could work with City Hall and with the streets in doing this. So San Francisco was kind of our heroes back then. So I want to acknowledge them and say thank you. What I would say that most people don't know about homelessness is how deadly it is. And when we've really looked hard, people living in Boston, we have about 95% of everybody who's homeless tonight will be in a shelter. And only about 5% will be out on the streets. And with people living in shelters, they die at 4 times the rate of someone the same age in the city of Boston. If you live on the streets, it jumps up to 10 to 12 times that rate. But then when you look at why are they dying, if you leave drug overdose aside, because that's, sort of up and down a little bit, but by far the leading causes of death are cancer, heart disease, and lung disease. And when I think of it like our lens of looking at this is how can we do the best possible health care for people who don't have homes or living on the streets, you've got to really take into account that this is a very sick population that needs all sorts of care. And nowhere is that magnified more than when they go into housing, as Beth could be the person to say that really figuring out how the healthcare system can work together with the housing and other systems to make lives better. And the last thing I'd say is I think what everybody has to come away with after 40 years in the same job, same full-time job, I'm more confused about what the solution to homelessness is than ever. It's a very, very complicated problem. And I know it's not going to get solved until all of us figure out how we're working together in all forms of government and not-for-profits and law enforcement. Everything has to be working together. I think I'd leave it at that because I'm too long.
Thank you, Jim. Kevin, what is one thing most people aren't aware of what it's really like to live on the streets of this city day by day?
Well, most people walk by homeless folks in the street. They either feel revulsion or anger or sadness or indifference. Homeless people can be two-dimensional cardboard cutouts to a lot of folks. But what I've come to find in nearly 50 years as a reporter on this, I wrote my first story in 1978 when I was a homeless college student myself in San Jose. No one really wants to be homeless. That's the thing. If you cut through the dysfunction, there's the mental illness, drug addiction, just trauma, especially among chronically homeless people. People want a roof, they want stability, they want safety, they want a door. And inside every single homeless person you see is the child that had all the hope in the world until bad luck, bad fate, bad choices led them down the ladder to the bottom. These people need our empathy. They need our attention. And one thing, my book is about 2 people I helped pull off the streets as a reporter here at the Chronicle over the last 25 years. And one thing that came home to me over all my years of reporting again and again, looking at the solutions that came along, then the compassion fatigue that came along, and then the let's try this other thing. No, let's be hard. No, let's be gentle. Let's do sober housing. Let's do harm reduction. All of the solutions that have been tried have great use, but it's a national problem that I didn't see. I was a reporter all over the world. I was also a traveling street singer, hitchhiking and sleeping in alleys. And so I got a pretty good look at how Europe treats homelessness, Australia, New Zealand. We don't have a living wage law nationally. We don't have national health. We don't have affordable housing help. You had those three things alone would probably cut our homelessness in half. But as it is, every one person that winds up in the street here, you got 4 more taking their place. And the thing to remember is that these are human beings that need the help, and we, as a country, do them a disservice. And that breaks my heart. I did nearly 50 years as a reporter till I retired a year ago. I kept thinking, gee, the solution's just around the corner. And these guys are working hard on it. I found that, every once in a while my editors would say, do a project on Homeless Incorporated, all the people who work on homelessness who, want the problem to perpetuate so they can keep making money off it. No, I found people are underpaid and overworked, and they are very sincere. Beth here, we spent some significant time doing stories about programs that really have wonderful promise, and the folks that you just pointed out in the crowd, they're among my heroes. You can't give up. It's a big problem, but just don't give up.
Thank you, Kevin. Larry, what is one thing most people don't understand about how a Franciscan charity like St. Anthony's Foundation responds to homelessness?
I think people do understand it. I don't know if people fully appreciate how important it is. It's not necessarily about programs or scale or policy. Part of it is, for me, how we empower our teams to build trust. The diversity of individuals that don't want to be in that circumstance, combined with the deadliness of it and the deep shame that sometimes comes from it, building trust allows you to enter into a space to allow for deep change. But doing it is not easy. And how do you, in the midst of the policies and programs, empower your teams to build trust? I'll tell you a story that I just recently heard. One of our front desk people, we have a guest. We call him guest because hospitality to us is sacred. He was from Venezuela, diabetic, unhoused, mute and deaf. And I just learned this recently. Do you know sign language? There's a Spanish sign language. I didn't. So English sign language doesn't work with Spanish sign language. And so there was lots of communication issues. His hemoglobin A1C was 13, which is a diabetic measure, out of control. But the team took him in. And it takes time. But the fact that they were willing to engage was huge. Here's the thing, we would see him twice a week, the team would, they're in the back. And one day, we had to cancel one of the appointments because I believe one of the practitioners were off. And he had scheduled the appointment on his birthday because he didn't have a place to go on his birthday. And he was going to go to the clinic because that's where he knew people. And it communicated to the staff, I'm really bummed out. I can't go to the clinic on the birthday. And Fabiola, our front desk, fabulous Fabiola, said, come on in. And they bought a cake, and they sang happy birthday to him. He's going to keep coming back to the clinic. He's going to keep engaged. And he never made it to the back of the office to see a doctor. There's something there that needs to be understood, because in the end, this is a human moment of suffering that's hard to categorize under one umbrella. And if you don't build teams and empower them to build trust, we're only going to get so far.
It's beautiful. Thank you, Larry. So if we're going to find a way through this problem, we have to be realistic that we have tried lots of things, and not all of them worked as well as we wanted them to. So I wanted to spend a little time on that and start with you, Kevin. You document in your book that there are many, many kind, talented, fantastic people who work trying to help unhoused people in our city. At the same time, you note, I think this is a quote, San Francisco spends more money per capita on homelessness than almost any other city. So why does the problem persist? Is it still not enough money, or do we spend on the wrong things? What were you thinking when you made that observation?
Well, one of the experts, you're a great expert. Keith is a wonderful resource for this issue. This is a very expensive city, and homelessness has spread to rural areas throughout the country in the last 10 years or so. And I've looked at homeless programs all over the country. This city has some of the best programs you're going to look at. Homeward Bound, the supportive housing complexes, the street counseling, street medicine. It's just incredibly expensive, and drugs are very easy to get. Not every chronically homeless person is drug addicted or an alcoholic, of course, but it just compounds the problem so massively. And people do come from other parts of the country. Most of the people who are homeless here became homeless while they were living here in the city. If you gave up and suddenly erased these programs, you wouldn't have the 8,000 or so people on the point-in-time count, or the 20,000 collectively through the year. You'd have 40 or 50,000. It's like the Australians. I was a writer and singer in Australia for a long time, and they have a saying called "pushing shit uphill." It falls back through your fingers as you're pushing it. Sorry, it's an Aussie thing, but that's kind of what you're dealing with. And condemning the people trying to solve the problem is the wrong way to look at it. If you weren't doing what you were doing, it would be infinitely worse.
Yeah, thank you. Jim, I want to follow up with you. There's an amazing book about you by Tracy Kidder and called Rough Sleepers. And in that book, which I just read in preparation to meet you, there's an experiment described where Medicaid agrees to vouchers to buy people who don't have anywhere to live an apartment, or rent them an apartment, which seems, at first, I thought this is going to be manna from heaven. But you and your team found out over a decade, 73 different people got to use one of those vouchers, yet 45% of them did not survive the decade. I have to imagine that was a very unpleasant surprise, and I wonder, what did that teach you?
Ooh, Keith, you're hitting a nerve here. So for years, for 20 years, we were taking care of people on the streets, and they could never get housed until Housing First programs came up. And it was like a miracle when they came. So the people that were never qualifying for housing all of a sudden became top of the list. And for us, that was just fabulous. And we watched people we've been caring for literally 20 years get into housing. And then, because we have a lot of homeless people on our board of directors, and our original thought was, once they get into housing, we'll pass them off to the services that you do in the neighborhood. But they wouldn't accept that. They wanted, if there was a relationship going on, they wanted to maintain that relationship. So we had to learn how to visit people who've been on the streets for years in their homes. So our team does, a few thousand home visits every year now. And we found, surprisingly, while it's incredibly wonderful, it's also incredibly challenging. And we learned in housing that the Housing First Support Network, and I'm guessing Beth would be the best person to talk about, is really underfunded. So people go from the streets where they have all these street smarts, where they have a little community, all of a sudden they're in a studio apartment, they don't know how to turn on. The first call I got in the middle of the night was, how do you do the clicker for the TV? And you realize that they just don't have the skills. They haven't had places before. Shopping is difficult. And most importantly, there's no community there, or there was not in these scattered site things. And people then relapsed, after being sober for years. And then they stopped going out to be where they could be seen every day, and we had to find them. And they died of cancer, heart disease, lung disease in their apartments. Some died of overdose because now they were shooting up alone with no one watching them. So we were thrilled with the housing, and there is no way this whole problem is going to get solved without housing. But for the very vulnerable, I think they need services. They really need services because they've been so scarred by what they've been through in their lives. I was talking today, we stopped talking about the social determinants of health in our program because the determinants of people's health happened 30 and 40 years ago when it was trauma as a child, or they were in terrible school systems or were underfunded and they weren't recognized to be ADD or didn't recognize a learning disability. And then they end up out on the streets with no skills. 25% of people who live on the streets of Boston cannot read or write. So you realize this problem isn't right now, the problem is way back. And so if we're gonna solve this problem, we need housing, but we also need to fix our social systems. We need to fix corrections, need to fix education. You go on, and you have to be sure these folks are cared for. We have to take care of them, and that's wildly underfunded. And I think that's why we saw when you look long-term at what happens after housing, we were stunned. Everybody looked like they did well for a year, but then as you go out to 3 years, 5 years, and 10 years, the number of people doing well goes way down, so that nobody was in housing 10 years later. And that's the kind of stuff I think we're going to have to come to grips with as we figure out what supports programs like Beth's are going to need.
Let's please, Beth, go to you, because I want to hear your perspective on this. I'm sure you know that famous study from Boston.
Yeah.
You also know, I think it's almost a quarter of overdoses in San Francisco are in housing. What does that teach us? Like, what is it that we need to do that we're not doing?
Yeah, Dr. Jim, when you say touch you, I think the things that you're really bringing up and raising are critically important. In housing, it's, once folks get housed, it's, and the door closes, it's when the work really begins. And I think that sometimes we forget that, right? We forget that folks that are moving into housing are extremely low income, need supports around stability. Often when they're in shelter, got 2 to 3 meals a day, didn't have to use what little income they had for rent, had access to laundry services, within 50 yards, and didn't have to pay for that either. And then, housing is absolutely essential, but when folks go in, there's a tremendous need for additional resources. And I think in supportive housing, we talk about living wages, and we have staff that need those living wages. And I just want to point that out that, in the system of care, we're trying to hire folks that can meet folks where they're at, peer supports, being able to kind of really capture the need for peers in housing to work on the issues of overdoses, right? I think that the overdoses in housing and supportive housing just speaks to the need for greater collaboration and the need to kind of really elevate some of the more promising peer models that we're seeing prevent overdoses or showing very few overdoses in their properties. And these aren't programs that are very costly, actually. I would say they're very affordable, and they're saving lives. And I think these are things that we absolutely have to look at. And when we've moved high acuity people into permanent supportive housing, at 100% tenancy, it's critical that we're partnering with Daniel and his team, on behavioral health, and I think that that's evolving, right? I think we've had some supports with clinicians in our properties, and Dr. Kwan and St. Anthony's raised their hand, and Dr. Bamberger has always been there, in and out of properties to really help people in terms of managing their health, right? And their, stabilizing in supportive housing. But St. Anthony's moved into one of our buildings as a federally qualified health center and partnered with us because we know, as folks that have case management and we have behavioral health, we have, I'll just say this, vast need for food. There's so much food insecurity, and how do folks stabilize when they're not getting healthy meals? It's always, I'm saying, it's dumbfounding to me, and I haven't figured out the solution to that, but it's a solution we all have to kind of think about in housing. But I think that partnerships, collaboration, It's absolutely essential, and for us to really raise up the peer support, behavioral health, and I'll say this one more thing, jobs. Like, some folks in supportive housing do stabilize and are really interested in economic opportunities, and those keep going away every single year. At the same time, we're facing, this, an IPS program. Folks are going to have to start doing, finding employment if they don't meet the eligibility for, Medi-Cal. So, us providers as a system, we're just, looking at a lot of different things that we have to pivot, address, try and find resources, try and find beautiful partnerships, and really try and work together to try and bring as many resources as we can, because we don't have all of these resources alone as a nonprofit.
Thanks, Beth. I want to focus now on the group of people. They're usually the toughest to help. So there are people who are, in the Great Depression, they would call down on their luck, who were just economically homeless. They lost their job, the rents went up too high, but they are able-bodied, and are easier to get back into a stable, safe state. But then there's another group, people who have a serious mental illness, like schizophrenia or meth-induced psychosis, or they're addicted they're addicted mentally ill. That population is really tough to help, as we all know. So I wanted to start with you, Dan. This is, a huge challenge for you and for our dear friend Kunal, because it's something that cuts across health, housing, sometimes public safety as well. I know you're fairly new, but I'd be curious, do you feel for that specific population, there's things you are launching that seem promising, or if there's not data that they're promising, that you personally just feel optimistic will make a difference?
Yes, and this is on. Yes, and I think we have categorically, on many dimensions, failed systemically to care for and also think about outcomes for those individuals. So maybe a different way I could have answered your first question. One of the things that folks often don't know about programs for unhoused individuals is, and I know multiple folks with history of street medicine and some of our teams, when I'm walking 6th Street or in the Tenderloin or anywhere, many of the folks that we are working with and folks see are not unhoused. They are housed, they're at ECS, they're in SRO, permanent supportive housing. And so housing is a necessary but not sufficient condition. And we recently, with Mayor's Office Kunal, Department of Housing Supportive Homelessness, we put our data together for about 9,000 clients in PSH in the city and DPH data, because almost all of those individuals are patients and clients of the Department of Public Health. We're their provider in some way, healthcare provider. And obviously you see what you expect around the prevalence of serious mental illness, co-occurring substance use disorder, aging with dementia. And a few things become very apparent too. Number one, there are a set of folks where we do not have a good solution in the system today to care for them. They are more complex than what permanent supportive housing is set up for. They often are being kicked out of many other settings of care, including skilled nursing facilities. They often have major behavioral dysregulation, cognitive dementia from years of substance use, traumatic brain injury, etc. And we just recently identified 79 in PSH who are the most acute. It has strong overlap with a population who's essentially lives at San Francisco General Hospital for a year or two at a time. We can never place them. What happens is then we find them, they make their way to permanent supportive housing. They're not nearly getting the right supports. We see them 300 ED emergency department visits in a single year. And also it creates great challenge for the PSH communities there. And so for all those pieces, one example of something that we are trying to pilot is for those individuals, instead of taking those individuals and just putting them into PSH without the right support or leaving them in the hospital, which is not good for anybody, we're going to try a pilot program where we work with some providers, whether here in San Francisco or nearby, to say, look, would you be willing to take Beth with this whole history of complexity and has bounced out of every setting of care in San Francisco, and we know that you can't handle her as is, but let's actually do a wraparound set of 24/7 support or a personal care attendant, other behavioral supports, and get them placed someplace that is not actually PSH, permanent supportive housing. It's not San Francisco General Hospital as a thesis for can we actually help folks in that part of the journey. But that's just one example where many different populations have converged on PSH. The staffing, often the supportive part of PSH is often not there, not for anyone's fault, just the level of clinical support and access. And for folks that really need significant case management and healthcare services, they get very little of that in PSH. So that's why, and I see Kunal, housing is a necessary but not sufficient condition to actually help those individuals be able to be successful in some sort of setting.
Thank you, Dan. Larry, I wanted to ask you another good book, and I realize I read too much, but I don't have a life, so is by Neil Gong, Sons, Daughters, and Sidewalk Psychotics, and I just finished it. And one of the points he makes there is the population of people who don't have anywhere to live and suffer from mental illness and addiction often refuse the offer of services when they're offered. And that's usually attributed by providers to their characteristics. You know, they're in denial, they don't have insight. Let's say maybe sometime that's true. But if people didn't want to eat in a restaurant, we would ask if the food was any good, right? And so I wonder on our side, on the provider side, what can we do to make it more attractive to be in touch with services?
I think we would need to better understand what we're not providing that where they are makes it more attractive. I suspect, I had this conversation with Terry, it probably has something to do with their community. We oftentimes think when we're trying to house somebody, oh, we're putting you in a better place. Are we? Have we asked? Who are your friends? Who do you trust? Do you feel safe? We project our perspective. You couldn't feel safe there. Maybe they do. And if we don't ask, we won't know. So I think that's probably one of the key design features I would suggest is we're trying to fix a life without knowing what they want. Yeah. I think my I mean, my parents did that for me too. When we all have dreams. I don't want to. I mean, and I don't want to say it in a way that we're doing it out of bad intent. It's just a certain amount of humility to think, hey, maybe this person has another vision, and maybe we can accommodate. Maybe we can't, but we should ask.
Thank you. So we're running near the end of this part of the discussion. So I want to turn to some things that are helping or could help. So I'm going to close this part by giving you each 1 minute. A minute is a unit of time that has 60 seconds in it. And ask each one of you, what is something that you see happening right now in our city or other cities? When you look at it, you think, that's important. We need to do more of that. What is your that? Jim.
Look at your clock here, yeah. Because this is such a complicated problem and there's so many different populations around, I think that's a hard one to do. But when I look at our own program, I think the most important thing that continues to stay is that the people who our program is designed by homeless people that had to sit down with the mayor and decide how they wanted to be served. For example, they wanted nothing to do with charities. So our program in 1985, where I had every friend I knew going to volunteer, they would not accept any volunteers because that, to them, smacked of charity. And then what they wanted most in their care, and this is now just the healthcare lens, was continuity. They wanted somebody to accompany them. So we had to be a small number of people, not a lot, who were going to be there full time. So that and the demand was if they were sick in the middle of the night, they want to be able to call a number and get someone they knew to answer the phone. And over time, I've started to realize there's a certain, we can't change much of the homelessness. We can take care of people. And the more we take care of people, I think the outcomes begin to get better. But it doesn't happen overnight. So I think we still, on our board of directors, for example, and Dan knows this well, we have homeless people who tell us what we can and can't do. So I think some secret is going to be how do you do continuity and how do you involve the people you're serving in where your programs are going.
Thank you, Jim. Larry.
Yeah, I was at a panel Somebody else, Bilal Mahmoud, was setting up a panel with the fire chief, police chief, DA Brooke Jenkins, and the sheriff. And what I saw there were these agencies trying to figure out how to work together around individuals. I thought that was amazing. And I think they were acknowledged this is kind of something new, but I think given that all these agencies are probably touching the same individuals with different lenses, I would say that's something I think would move us to a better place.
Thanks, Larry. Beth.
Yeah, thank you. I mentioned it before, but I think one of the most promising things we've seen is really kind of the peer-based folks who live in supportive housing, helping, their neighbors, who are using, so they're not alone, and really working to prevent overdoses when you're by yourself in housing. And so that's shown great promise, and we're piloting that program in one of our buildings right now, one of our larger buildings at 1064 Mission. And, I think that's something that, it's not a costly program, like I said, and it does save lives. So I think that's really important for us to focus on that and to elevate the peers who are doing that work. But I would say, I don't know that we've figured out what works, to your point, over 40 years. And I think it's just that's the challenge, right? So I think we have to challenge ourselves, everyone in here, and none of us have all the answers, and I think to be transparent and gracious in acknowledging that, because I certainly don't. But I think we need to be bold, and I think we need to really force ourselves to collaborate, and I think we have to kind of, as a community, really kind of identify what is it that we want to achieve. What is, are we going to get to zero? I think for many of us in this room working on the issue of homelessness and asking yourselves, how can we solve this, right? We haven't solved family homelessness in San Francisco, right? So that's, I just put that challenge always in front of myself and our team and to you. I think this in San Francisco is solvable. I always have, or I should not be up here, right? And I think we all have to work really hard together. It's very complex. But I think we need to kind of get on the same page, identify how we're going to get to zero, right? I think because there's, in San Francisco, elections and new leaders and new plans and, every 4 years or every 8 years, it's a new plan, all due respect. But I think we have to kind of have a plan and work toward that as a community and support each other to achieve that success. So I'll stop there.
Thank you, Beth. Dan.
I think, on the other side of the spectrum, I think we are trying to do a lot together with other providers across the city where we can quickly get someone from the street into some sort of care. And that's crisis stabilization at 822 Geary, for example. At 33 Goff, we have a shelter that has an incredibly high level of complex care management. And the idea is if someone is in any sort of mental health and or substance use crisis, we can get them someplace. We can quickly address both sides of their mental health and substance use needs. We can prescribe medications. We can get someone off the street. We can then plug them into other places. 822 Geary, which we stood up this past spring, the majority of people that we're discharging who are coming off the street in great amounts of crisis and distress, we are getting into some sort of next step from a residential treatment or another place that they're going for continuing care, which is really, really high for numbers. And so things of that sort where when someone is ready, or we have a program called Restore, I won't talk about that for the 60 seconds now. If we have some place we can get someone when they're ready to go someplace and we can actually help meet needs and move them along on their journey, that's what we need to do more of as well.
Thank you, Dan. Kevin.
Well, I wrote about Dan Lurie quite a lot through my career. So I think he understands the science of homelessness in a way that not a whole lot of other folks in public office do. I'm inspired by the openness to a breadth of programs, sober living, harm reduction, wraparound for mental health, and for drug rehab. That's what it takes. The fact that we have to keep reinventing the damn wheel is, as a journalist for nearly 50 years, is a little frustrating, but it's always the same answer. You can't just put someone who has severe mental and drug or alcohol problems in the same population with the same care that your typical supportive housing person needs, which your typical supportive housing person needs a bit of care, care management and then can be okay. It needs intensive. I've spent a lot of time in criminal prisons for the mentally ill around the world. Other places do it better. Some place like Napa State does it really well. It's very expensive. You're either going to do that or you're going to spend about $90 grand a year on a typically chronically homeless person in care and services. It's cheaper to do the right thing, and I'm glad that there's a resurgence of wanting to do the right thing about that kind of care.
Thank you, Kevin. That's a great note to close this part of our program. Thank you, everybody. So we're now going to move to questions and answers from the audience. All right. In the current political climate, characterized by impatience and frustration with visible homelessness, how do you balance your policy decisions with compassion and care for the most vulnerable of our residents?
Kevin was saying something to me. I missed
Yeah,
a bit. Were you
sorry.
addressing it at something? Sorry, I blame him. Was that a question for me, and what was the beginning of it? I apologize.
In the current political climate, so this question is for, I should have said, I'm sorry, Kunal Modi or Daniel Tsai. In the current political climate, characterized by impatience and frustration with visible homelessness, how do you balance your policy decisions with compassion and care for the most vulnerable of our residents? So I think what that means is when many people are angry and frustrated, how do you maintain some caring in that political environment?
Well, Kunal addressed some of this at the beginning. I feel like every single day somebody is yelling at me or angry at me or us, and hopefully that means we're trying to find the right place on the end. In San Francisco, there are, and I even see for folks I recognize, that there are so many different, very strong views. You mentioned there's harm reduction, there's sober living and recovery-oriented pieces, there's provide more services, less services, all these things. And all of those have legitimate points. I don't think anyone has cornered the market exclusively on understanding the crisis, the behavioral health, public health crisis we have, and all of the factors driving that. And at the same time, I refuse to believe and accept that we have to end up choosing between compassion and also forward movement. And I actually, Jim, I always remember there was, when I was cutting here healthcare for the homeless, Boston Healthcare for the Homeless, you had an AmeriCorps, like social worker, not social worker, community health worker there. She was very, very good. And I watched her and the clients we worked with have treat someone as with compassion, non-judgmentalism, but also expectations and a belief that they could have forward progress. And she would take no nonsense when they talked back, but she'd also be the most loving, kind person. And here in San Francisco, we are trying to mix a balance of those things where we can meet folks where they are, but also provide a continuum of options, including for those that want to be in a very different type of setting, and help people actually make forward progress with very treatment-forward options that help people move through that journey. And so those are things every day where I think kind of pull all those people together. But I walk the streets every single day, as do many people here, and I feel both all the range of emotions you felt and that we can and need to do better in how we structure supports, the expectations we have, all of the above. And so in my mind, it's an and as we look at all of these different approaches. And I don't think anyone can argue that what's happening right now with almost 2 people dying a day of overdoses is working. And there's more we can do. That's not a fault of folks. That's the opportunity we have for the folks that we serve.
Kevin, actually, if I'm going to just jump in because I'm going to quote you, and then let you respond. Sure. This is my favorite line in your book because you sound so Franciscan. Anytime you want to come stand, you should hang out. Every homeless person, quote, was somebody's baby for at least a brief shining time, a child with potential, or an adult who wanted a life of security and love. You need to get past the grime and ruin to see it, to hear it, to feel it, but it's there. How do you do that?
It's not easy. I was just going to say, guys like you, who I've seen come and go over 50 years, you got to have a steel spine, because you're kind of in the middle of a crap sandwich. The activists are pissed off at you all the time. The policymakers are pissed off at you all the time. They want the problem to be done. And at a certain point, a lot of people just say, do whatever you got to do. You have to stay compassionate with it, because just throwing people in jail doesn't work. I was just up in Grants Pass, Oregon, where that Supreme Court thing came, the ruling came from about a year ago. They tried just jailing people. Didn't work. They come out straight back to the street. You have to do the right thing, and you have to believe in that and remember that. Even though you feel discouraged, when I was, in the street myself, because I was a very young man, and as a homeless reporter, you start getting discouraged. You see stuff not being fixed. You see stuff not happening the way you think it should happen. You just have to find it in yourself to believe. And I think you're that kind of guy who likes to believe. And you, I know you, and I know all four of these people. They believe in it, and you have to remind yourself of that belief. You too, for that matter.
Thank you, Kevin.
There you go.
Thank you, Kevin. So here's our last question. This one I'm going to suggest Larry answer. I'm tossing the ball in the air for you to dunk it, Chief, okay? I teach high school students, and I'm now in San Francisco. What is the best, most effective way to help students be aware of the complexities of homelessness? Thank you.
Yeah. Keith is helping me highlight our volunteer program. and I
make the big money.
Yeah. I say that partially in jest, but the reason why St. Anthony's has a volunteer program is yes, it really helps, and it immerses people in the experience that changes their own hearts. Father Alfred had a moment way back. He was our founder. There was a moment when I think Bill Graham, at that time, he's one of those rock promoters, wanted to put on a big rock concert in Golden Gate Park and make $1 million, and he refused to do it. He says, doing that, people donating the money would never really understand what we're doing. I want them there in the dining room, in the free clothing program, volunteering. Because that's when they will really understand, face to face, what it means to be of service, and more importantly, how close there but the grace of God go I. And so I think, yeah, come volunteer.
Thank you, Larry. So those are all our audience questions. It's hard to sum up such an amazing panel. I will just pick up a couple of themes. One is people talked about despair. Despair is an understandable impulse when you've been trying hard for a long time and a problem is still in front of you. It's natural to feel that, but that once we start to feel that, then it becomes true. When we give up, the problem is there forever. The only way problems change is when we have the vision that it might be different, and we hope it might be different. For me, that hope comes largely from extraordinary leaders like these fine people here. So I hope you will join me in thanking them for inspiring us all tonight.
Good to see you in person, Beth. Thanks.
Well, you as well. Nice to meet you. Good luck with everything.
We should catch up at some time soon.
Sorry, wait, sorry.
Come on, folks.
Hang on. Bad hosting, my bad, sorry. Please forgive me. We're going to have a little music. Kevin is a man
stick around.
Kevin is a man of many parts, not just a thinker and a journalist, but also a musician, and he's going to play us a song. Okay. Take it away, boss.
All right, guys. Sorry. This is your cheap version of multimedia for the evening. I picked this song up many years ago when I was a street musician sleeping in alleys when I was very young. It was personal at the time, and it's still personal today to me. I was walking by the graveyard late last Friday night. I heard somebody yelling, it sounded like a fight. It was just a drunken hobo dancing circles in the night, pouring whiskey on the headstones in the blue moonlight. So often have I wondered where these homeless brothers go, down in some hidden valley where their sorrows cannot show, where the police cannot find them, where the wanted man can go. There's freedom when you're walking, even though you're walking slow. Smash your bottle on a gravestone and live while you can. That homeless brother is my friend. It's hard to be a pack rat, it's hard to be a beau. Yeah, living so much harder where the heartless people go. Somewhere the dogs are barking and the children seem to know. Even Jesus on the highway was a lost hobo. And they hear a holy silence from the pimples in the hill. They see his ragged tatters as another kind of thrill. And they envy him the sunshine, but they pity him the chill. And they're sad to do their living for some other kind of thrill. Smash your bottle on a gravestone and live while you can. That homeless brother is my friend. Somewhere there was a woman, somewhere there was a child, somewhere there was a cottage where the marigolds grew wild. But somewhere's just like nowhere when you leave it for a while. You'll find the broken-hearted when you're traveling jungle style. Down the bowels of a broken land where numbers live like men, where those who keep their senses have them taken back again. Where addiction lays souls to waste, where madmen don't pretend, where wealth has no beginning, poverty no end. Smash a bottle on a gravestone and live while you can. That homeless brother is my friend. That homeless brother is my friend. Thank you. Thanks for being here.
Sorry, man. I'm sorry.
That's okay. It's all
My
right.
cognitive load was at my limit. I was like, oh, God, stupid.
Yeah, you did a tough job.